Imagine two clinics. In the first, a rushed doctor scans your history, types through the appointment, and has only minutes to think. In the second, an AI has already organized your record, flagged unusual patterns, and prepared questions, but a human doctor still makes the decision. Which clinic represents the future? Probably the second one. AI is already entering medicine, but the phrase AI doctor hides several very different technologies. One system may highlight a suspicious area on a scan. Another may summarize a medical record. A chatbot may suggest possible diagnoses. These tools do not have the same evidence, the same risks, or the same legal role. So the real question is not simply, can AI diagnose? It is, which parts of a doctor's work can AI do reliably, under what supervision, and who is responsible when it is wrong? Start with what AI already does well. It can search huge amounts of information quickly. It can turn a long chart into a short summary, draft a clinical note, detect patterns in images, and create a list of possibilities a clinician might consider. The FDA now maintains a growing list of AI-enabled medical devices authorized for specific uses. But that detail matters. These are defined tools for defined jobs. Authorization of an algorithm that helps analyze an ECG or an image is not authorization of a general autonomous doctor. The evidence for collaboration is becoming more interesting. In one randomized controlled trial, 92 practicing physicians worked through complex simulated patient management cases. Doctors using GPT-4 plus conventional resources scored, on average, 6.5 percentage points higher than doctors using conventional resources alone. That is a meaningful result. It suggests AI can help a doctor consider tests, treatments, and risks more completely. Another study evaluated an AI system called Amy on 302 difficult, published medical cases. Clinicians assisted by Amy included the correct diagnosis in their top 10 possibilities, 51.7% of the time. Before assistance, the figure was 36.1%. With conventional search, it was 44.4%. Again, the useful pattern is not human versus machine. It is a human getting a stronger second look from a machine. There is also evidence from a lower middle-income setting. After 20 hours of AI literacy training, physicians using GPT-4o performed substantially better on 6 simulated diagnostic cases than physicians using ordinary resources. That could matter where specialists are scarce. But the training is part of the result. The tool did not simply arrive and make everyone better. Clinicians learned how to question it, test its suggestions, and recognize its weaknesses. Now for the limits. These studies mostly used written cases or simulations. Real medicine is messier. A patient may describe pain vaguely, forget a medication, minimize a symptom, or show a physical sign that never appears in a text prompt. A doctor watches how someone breathes, notices confusion, feels an abdomen, examines a rash, and changes course when the situation changes. AI can analyze data it receives. It cannot guarantee that the right data were collected in the first place. AI also makes a uniquely dangerous kind of error. It can be wrong in fluent, confident language. The World Health Organization warns that large medical AI models can produce false, inaccurate, biased, or incomplete statements. They can also create automation bias, the tendency for a human to trust the machine and overlook a warning sign they might otherwise catch. In healthcare, a convincing explanation is not the same thing as a correct one. Bias creates another problem. If a model was trained on data that underrepresents certain populations, its performance may fall exactly where health systems already have gaps. Privacy matters too. A health conversation can contain medications, diagnoses, family history, mental health details, and identifying information. Putting that into an ordinary consumer chatbot may create risks that are very different from using an approved system inside a protected clinical workflow. Then there is accountability. A diagnosis is not merely an answer. It begins a chain of responsibility: choosing a test, explaining uncertainty, obtaining informed consent, balancing side effects, coordinating care, monitoring what happens next, and responding when a treatment fails. A patient needs to know who is answerable for those decisions. Today, that responsibility still sits with licensed professionals and health systems, not with a text generator. So, Which medical tasks are most likely to change first? Documentation is already changing. The American medical screening and triage will expand too. AI may identify which scan needs urgent review, which laboratory pattern deserves attention, or which message should be escalated. It may help clinicians generate a broader differential diagnosis and check guidelines at the point of care. In rural or understaffed settings, carefully designed systems could extend specialist knowledge. But extend is the key word. A tool that helps a nurse or doctor reach more people is different from a system that leaves patients alone with an unverified answer. The job of the doctor will change. Doctors may spend less time hunting through records and more time verifying machine-generated summaries. They may need to understand model limitations, data quality, and uncertainty. The best clinicians will not be the ones who blindly accept AI or the ones who refuse it. They will know when to use it, when to challenge it, and when to turn it off. What should you do as a patient? Use AI to prepare, not to surrender control. It can help you organize symptoms, translate medical language, or draft questions for an appointment. Ask whether a tool is designed for medical use, whether your data are protected, and whether a qualified professional reviews the output. Never let a chatbot's reassurance delay urgent care. Chest pain, severe breathing difficulty, sudden weakness, major bleeding, or rapidly worsening symptoms need real medical attention. Will AI replace your doctor? Not as one dramatic switch. It will replace pieces of the workflow, reshape decisions, and expose weak systems that rely on rushed, fragmented care. Some roles may shrink, new ones will appear. But medicine is not only pattern recognition. It is observation, responsibility, communication, physical care, and trust under uncertainty. The most realistic future is not AI instead of doctors. It is competent clinicians using tested AI with clear limits and human accountability. The question that matters is no longer whether your doctor will use AI. It is whether they will use it well, and whether the health system will keep a human responsible for your care. This video is general education, not personal medical advice. For symptoms, diagnosis, or treatment decisions, speak with a qualified health professional.